I have a patient, please? Come on over. She's like, I get to sit on the stretcher. Sit right up here. Yes, go the hard way. I made it very difficult by design. I'm so sorry that you ended up in the emergency room today. We're going to practice a chest x-ray on a stretcher, okay? This is going to count as your wheelchair or stretcher or portable chest, okay? Want to get as close to 72 inches as you can, okay? Mind you that in some of these rooms you really don't have the luxury of space. Especially at Barlow, we don't have the luxury of space. If I turn my portable machine, I hit a patient.
That's kind of how it is now, so you're okay.
Yeah, exactly how it is now. So, you have these steps right here, April, real quick.
You don't want to hit me?
I don't want to hit you. All right, first thing I'm going to do, lay all the way back. Great. Usually, most of the time, I put my cassettes in behind a patient on a portable crosswise. Again, same rules apply. If they look like their lungs are going to be really long, then maybe I put it in portrait. Okay, what I'm going to do, grab the edge of the stretcher, slide that behind your back just like that. Make sure that I've got an inch or two above the top of the shoulders. Make sure that my marker is on it as well. Okay?
So your marker is legitly on there right now?
Legitly.
Okay.
I love that word. Legitly.
And you said 2 inches, right?
1 to 2 inches above the top of the shoulder, yeah. And I want my the angulation of my tube to match the angulation of my board, right? I don't want to have too much of a steep angle on it. I don't want to undershoot it, because then I would make a lordotic out of something I don't want to be lordotic. Close to 72. If you ever want to measure, there's a handy measuring tape here. Okay, for those of you that like measuring tape. I'm going to collimate down to the size of the cassette, making sure that we are not off the top. Okay, hands are going to be down by the side. Great. Take a deep breath in, pull it all the way out. Take another deep breath. Hold it, don't move, don't breathe. Bang. Breathe. You'll also notice there is a 6-foot cord on this. Why? Because we don't want to get irradiated. And the rooms in a hospital don't have the lead that our x-ray rooms do. So when I'm doing a portable, x-ray, x-ray, you see everybody scurry like cockroaches. Take a deep breath. Blow it all the way out. Take another deep breath. Hold it. If they are on a ventilator, are they going to be able to follow your instructions for breathing?
No.
No. So what are you going to do?
Compensate. You look for the inspiration.
Yes. Don't question yourself. I saw it. I saw it in your face. You're going to wait for the machine to go and fill their lungs with air. Okay? That means most of the time on a portable, especially if you're doing one on a patient that's ventilated, you are going to do what's called getting on the rotor. You're going to press the exposure button down halfway to hear the tube start turning. You are making your cloud of electrons. Okay? You're doing thermionic emission. So that when the patient finally goes, you're ready to pull that over to the anode and make your x-rays.
How long can you do that?
How can you do what?
How long can you half press it?
You don't want to hold it too long, because that actually will start to have a negative effect on your electrons. So don't do it for more than like 20 seconds at most, okay? Which by that time you should have a good idea of when their next breath is coming, okay? So take a moment. 2 things I want you guys to prioritize from this learning setup here. I want you to get used to manipulating the portable machine, and I want you to get used to sliding, a cassette behind your patient's back, okay? Because this will happen often that you have to do, especially in the ICU, where they are literally dead weight. Biggest chest x-ray I ever did was on a 400-pound patient, okay? And he, no, 600 pounds. And he was not conscious. I was very sweaty by the end of that.
Good luck finding a nurse to help you.
They scattered like cockroaches. All right, questions?
There's a lot of cockroaches in hospitals.
There are. A lot of iatrogenic infections.
Can you
Get it.
holding the button while like just one more time, please. Sorry.
Sure.
So you said like.
So you will see how there's a little red ring here?
Yeah.
If I go just halfway, I am rotaring. You will hear the unit go, and then it will be making my thermionic emission cloud until I go
Oh, and it's like a
exposure.
Okay.
Okay,
Thank you.
collimator button there. So you can see your light.
Thank you. Thank you.
And you will see collimator button, collimator shutters, KVP, mass. One thing you'll notice about a portable machine, this is an older portable machine, this is one that I had whenever I was an X-ray student, not this particular one, but this model, is that you don't have the luxury of changing your exposure time, right? We have mass, we have KVP. So oftentimes, especially with digital systems now, on a portable, it's more beneficial to raise your KVP than it is to raise your mass, because if I raise my mass, I'm going to have a long exposure, which is not good on a KUB, it's not good on the chest, especially if they're on a vent, right? So to keep my exposure short on a chest, probably what I would do is if I had a grid, something like that. Okay? Questions?
So you said on older machines you raise KVP instead of mass?
I would go a little higher on my KVP instead of raising my mass to a really high level. Which means on an abdomen, I might shoot a portable abdomen on like 90, 85, 90, probably 90. And so that I can lower my mass a little bit, because the digital system is going to adjust for that technique. Okay. Questions? Great. Let's practice. Who wants to be the first patient? Portables happen a lot in a hospital. They happen on the floors. They happen in the units. They happen in the ER. And don't everybody jump all up at once. Go ahead. Get used to talking. Hello, I'm Brad from radiology. I love doing x-rays. I also love Star Trek and Doctor Who. How are you today? Great. I'm so sorry you ended up in the ER. Let me have you lean all the way back. Most of the time these patients are not going to help you at all, especially if they're really feeling bad or sick. So you're going to grab the sheet, slide that behind your back ever so gently, and make your adjustments based off that. Okay? Anybody?
4. 10-4. Like okay. I was like 4-11.
Questions? Anybody? All right, get hands on. Who's going to do it?
Oh, I'm April from radiology. Not yet, but soon. Sorry, you're here in the hospital. I'm not gonna speak.
Go that way.
So I'm gonna take a couple pictures of your chest. So can you lean back, please?
If they can help you, cool. If they can't, then this is the way we're going to have to do it. There we go.
Is that right? Oh, shoot.
You're good.
So what do you know about a chest x-ray from what we just learned on a bucky?
Well, it
You
probably
want it
needs
to
to go
be-
up a little bit
Yeah,
more then.
you want it to be a couple of 1 to 2 inches above the top of the shoulder.
Okay.
Probably 1 inch since it's crosswise. Okay, we're going to feel that, make sure she's nice and centered. How are we going to make sure she's centered? We're going to feel both sides of the cassette and adjust her body. based
Oh,
off of
adjust
that.
her body. Okay.
Okay.
Yeah.
Oh,
See?
Any tips?
I was just gonna say for the rotor part, it also works for your peds patients when they're crying and crying and crying, and then they take that 1 second of
So
that's
right.
when you shoot it.
Right before they explode.
Yeah,
It's so funny.
yeah,
It used to be my
always.
favorite because they go
Yeah, it's like that little second.
and they're red, and then they go.
Perfect.
Now it's happening. With help or no help? Let me know.
No.
Okay.
Just grab the sheet, push it behind her. There you go. Make it one swift, fluid movement. My coworker at Barlow, when he does a portable, he like wraps his arm around the patient and pulls them forward.
Oh yeah, some people do
And he
that.
hurt his back.
Yeah.
He got bitten one time.
Oh yeah,
And I
yeah.
was like, why do you do it that way?
Some of the beds are not equipped even behind a sheet to push it. So find a nurse.
Yeah.
That's why I've heard like you have to have assistance. Like they should want to.
Yeah.
Just put a little low on this side. Raise it up a little.
Nurses get a lot of bad rap.
There we go.
I mean, I hear it for everything.
Head back. Great. And everybody get used to manipulating this too. Okay? You will find that this is a different animal than that one. Okay? I love a portable machine.
Same.
It seems a little bit more easier than having them stand there because you have more control of them.
That's why I love portables.
Oh,
But it does require more, there are more factors that you have to consider when you do portables. And you have to have a better knowledge of techniques overall. Because when you do it in the room, you're going to walk up to a nice touchscreen console, which you probably do on a newer portable. This is an old one. But you press PA chest, it pulls up a technique. You have AEC cells that will give you a perfect exposure as long as you're positioned correctly. On a portable, most of the time, you don't have that luxury.
so
Unless they're
this
like
you
a
have to
newer
have a
digital.
brain, and that one you really don't.
Yeah.
I mean, it's really like self.
Yeah.
But
So when
overall,
they say
like, you're
you
gonna
just-
get used to the numbers, right? Like when you're
Yes.
inputting them, I feel like it'll just become like.
Yeah.
Oh, okay.
And one of the biggest tips that I give you guys when you go to clinicals is write down your technique that you see pop up on the screen for everything that you shoot. Because then you'll start to get an idea of the ballpark of what the technique is for things. If you're in a situation where you have to set a technique.
So when you do that, then should you write also the geometric factors of the patient as well? Or does that really matter?
It's not a bad idea to be like, this was a hypersthenic patient, right? This was a good chest x-ray technique for a hypersthenic patient. This is a good technique for an asthenic patient. And think about it that way. Average chest x-ray.
Okay.
Right.
Because I know it changes, so that's.
And you will notice that it changes from unit to unit and facility to facility. If a unit is older, it might require a higher technique to get a good x-ray because the components are kind of wearing out. The filament's a little old, the anode's a little old, right? I think if we shot something on this, it would be, we'd have to go up a little bit in technique.
Oh, Rusty. I have a question, Professor. Usually it has AEC or like usually it has KVP mass adjusted, you said, right? Even then?
I'm sorry, what?
Usually it has like KVP or mass adjusted already, like on its own, like automatically,
For a portable?
or either way, you know. We have to adjust this portable.
One in the room.
On a portable, you're probably going to have to set a technique.
Oh, okay.
I don't know about newer digital porters.
No, it'll be set up.
It'll be set up?
Yeah.
Everybody's growing up at an easier age than I did. There's your answer.
Thank you.
Yeah. That's the younger x-ray.
But you still have to think about your patient. Not every patient is the same. Yeah. So just because it tells you 100 at 3 and your patient doesn't look like it would penetrate enough, then you need to increase.
So that's why I was asking about.
Yeah.
Because like I said before, in the rooms on even newer machines and probably newer portables, we have like the average technique. Like fixed KVP is for an average size patient. What you'll also notice on newer machines is that they have density controls. So if I have a patient that's really large, I could bump the density up 2 levels. That's going to be the same as doing a 1550 kind of manipulation of my technique to give me more technique for the bigger patient. Make sense?
Yeah.
And sometimes you're doing a newborn, which is the size of your hand. So you would bring it all the way down.
Yeah, there's no fixed technique for that.
Yeah.
One. You have to figure that out.
You're
So
just,
it's just like a standard, right? Like the ones that come in like the newer machines, standard, but you have those.
Even on the dummy-proof machines, we have to know what we're doing
yes.
to the degree.
Always double check.
That's right. Who wants to practice next? Yes.
For this exam, how do you determine like which angle you shoot the image at? Like,
So I'm looking here, matching that angle here. I eyeball it, pretty much. Yeah.
And there's a tape measure, isn't there?
If you want to measure your SID.
Angle it to the sternum. Fully over the patient. You
And I
can
would
what?
try.
Yeah. You can. This is how it would be.
I was just getting my teeth.
You want me to like act like a normal patient, or just act like, nah, bro, get out of here?
Okay.
Is that me like yelling and screaming?
What's the marker will be on the left side? It could be on either side. Oh, because you're doing AP, you could put it on the left or right.
But with the left marker.
No, it doesn't matter.
Use either or, either side.
So if you're seeing both sides on something,
It can be either.
right? Yeah. So
Right, he said right, oh my God.
like pelvis, abdomen, chest, skull, any image that I do, I'm gonna see, if it's AP or PA, I'm gonna see both sides. So I can use left or right.
So
If it's a left hand,
use the left.
left marker. Right hand,
And then if you turn your body, whatever's touching that IR.
yes. Yes.
Or down,
Yes.
laying down, okay. I know it seems simple, but.
No, April, you're doing great. I love your costume.
Because there's so many different, this side, that side, this side. Like the arms and legs, I think.
Now, can you set this up for me?
Well, those aren't moving.
They're not changing sides.
Just grab it. No buttons on this one. Do I turn it? And now. There you go. And don't worry, we will get much more practice with all of this as we keep moving forward. Portables keep coming back, April. I know you're so.
Well, it seems easier to use the portable in some sense, just because you're in control, and then having the patient in control. Because I know I move a lot, like, you're probably like, stop moving. So I think that's the hard part. I'm just thinking of myself being irritated. Like, I'm probably irritated.
Man,
Stop
where's the
moving.
thing? I gotta go all the way. All right. Take one deep breath. Breathe out. One more deep breath. Hold. Really important. Put your head back. There you go. Okay.
Oh.
What about hand placement? What about hand? Sorry. Hand placement. Usually it's going to be patient with their hands just down by their sides. You just don't want to make sure they're not like this. Also, if they're in an ICU, they may have a vent line. If they have a vent line, don't touch it. Okay, even if it's lying over their anatomy, you can try to do tiny adjustments, but my general rule is don't ever touch it. Because if you do something that causes them to extubate, that is now an emergency. Okay, so leave that tube alone. If they have EKG leads, do your best to wrangle them and move them off. Kind of impossible because they are stuck to their chest and they're in 3 different places or 4 different places. If they have, what else? Oxygen line. If they're not vented and they're just on an oxygen, like a nasal cannula, drape it over the top of their shoulder, get it out of the way. Anything else?
I think.
What happens if they have like that monitor, like the portable monitor, like in the pocket?
Oh, yeah, you
the
take that
EKG
out.
monitor
Oh, that one.
in their pocket,
Yeah.
like the big box thing.
Yeah.
Just pull it out and lay it on the side.
Okay.
So this, you chin up then?
Chin up.
So
Your
there
head
was
back.
a chin up somewhere, I knew it. See, I asked you and you said,
It's
not
the
chin
little
up,
things
and then
for
it's a
you,
chin-
huh?
yes. Because it's floating there, like, where does it go? It needs to go in a folder in my head. It's in a folder. It's on the stretcher.
Double click it, April. Double
Yes.
click it. All right.
Done.
Any
It's
questions?
put away.
All right. Good job, guys. Very good. All right. Who's next?
You said the midpoint is sternum?
Yeah, angle the tube to the sternum.
All right. My name is Chris. Will be X-ray tech. What's your name and date of birth?
Isaiah Manning, July 9th, 2001.
How you doing? Is they doing all right? I'm gonna take an X-ray for you today. I'm gonna put this behind you.
You don't need to be in the ER. It's fine. It's in a moment.
Go ahead and lay back.
Wow.
Gotcha.
My favorites used to be the ones that would come through the ER and go, oh, I
Okay.
need Dilaudid. I need morphine.
You can relax your hands, put them on your side. I want to check the SID here. Where's the measuring tape? Measuring.
You didn't pull it out yet.
Okay, rock and roller. Okay. Are you a rock and roller?
Here it is.
Only on Saturdays.
Where are you measuring that SID from with this tube pointed at the floor?
Oh, you're right. Rookie
Technically, it's at
mistake.
his feet.
Rookie mistake. It should be a caudating.
Yes.
Somebody's been doing their Clover learning video.
No, that's right.
It's
Here at 60-ish, that's an abundance of room for one of these small ER rooms or hospital rooms.
Is it really? Some of them you just have to
You do the
what
best you
have to
can. You do the best you can. You lower the bed as much as you can, lower the stretcher as much as you can.
At Kaiser, they have a lot of them.
Machines are usually bigger, a little bigger than these.
Now they've actually gotten smaller. This is a really old machine.
I think you have to move the machine back itself to be straight. Or no?
I want to break this thing here.
Making your life very
Sorry. Sorry, sir.
And you're
You're on the
blinding your
camera now.
picture. Let me help you. Here. Let me help you. Sometimes you gotta go back to square one.
You gotta move Big Bertha over here.
Guys, this is 20 years of experience behind moving this machine around. You guys will be here, I promise you.
How old is this machine?
Probably 25 years old.
Yeah.
Whenever I was an X-ray student, this is what the hospital had. GE AMX 4.
Fuji gave up or what?
Fuji is really more of an imaging,
Just
like
an icon
the
like that.
IPs, the imaging system kind of thing. Philips, Siemens, GE, they make the machines. Philips are not my favorite, Siemens are my second favorite, and GE is my number one. I'm curious what we're shooting on this X-ray.
Chest. I was checking the margin of the 2 inches. It seems pretty good though. To me, it seems pretty good. Oh, I mean, maybe I think the collimations. I can collimate more down.
Whoa. No.
I feel like we're going to be clipping a little bit at the top of his lungs.
Because it goes to the shoulder. Like when the light's on in this position, would it be out to the almost to the shoulders to the first rib?
Sorry?
Nothing. No, I'm saying the light, would it hit almost the first rib? Like if you're gonna count them. Right?
Oh, yeah. I see what you mean. It would probably clip the first rib actually with that collimation.
When that's what it should be.
There we go.
The first rib, right?
First rib is up here.
Yeah, but the light is hitting it.
I'm gonna be honest with you, I'm not understanding.
The light is hitting, okay, we're gonna count ribs, like, but it hits the top of the first rib, so the light should hit the top. No,
The light should be above.
above it.
Yeah.
Okay, that's
Yeah,
what I.
we want the entire first rib included. Okay. Cool? Make sense?
Of the first rib then.
So obviously misread them, and then I was going wrong because I was too far.
Yeah. I think we're too far. And we only have so much height that we can get out of these machines. Okay. Okay, take a deep breath. Blow the breath all the way out. Take another deep breath in. I thought you were telling me that.
Sorry, I wanted to practice actually.
I'm here today. Go ahead. You're breathing. What are your breathing instructions?
Two breaths. We're gonna take a deep breath in, breathe out. Oh, chin back, sir. I didn't see that.
I love that performative breathing too. It was like,
breathe in one more time and hold your breath. Good.
all right. Who else?
So professional.
I'm trying.
No, it's okay.
When you're passing cassettes with another tech in a room, don't pass it over the patient, especially over their head if you can help it.
Good morning, I'm Josh, your tech for today. We'll be doing a chest x-ray. Can I get your name? And your date of birth? Okay, so I'm gonna slide this in the back.
Since 2001, God, I feel ancient. Any feedback?
They're doing good for the portable. They're doing good for the portable.
This is going to take the longest to finesse when they get to clinicals.
Yeah.
I have one question. If there aren't able to stand or just sit up straight and they're slanted, how do you go?
Best you can.
Unslant
You want to try
them.
to like rotate them using the sheet. The sheet. This is a rule for everybody. A big tip for everybody. When you're doing any imaging, anywhere, the sheet is going to be your best friend. Whether they're on the table, whether they're in a stretcher, because you cannot manipulate a patient by grabbing them. You're going to hurt them for one, maybe assault them. But use the sheet to move them. If they're slanted, right? If he was a little slanted this way, sorry, Chris, I'm going to trick you around here. Then we're going to come over here to this side, grab the sheet, twist his hips until he's straight, okay? If he's a contracted little old person, we're going to shift his body and maybe tilt him up and put a sponge under his side to hold him there, okay? Also, big tip, anywhere, never leave the side rails down, ever, okay?
I'm so glad you taught that on the last patient.
Yes.
You know?
Yes.
Never too late.
Always when it's important, April, never before.
He wanted you to fall before. So obviously you have to put it in, or put it back up after you put that thing, cassette. Right?
Yes. And tell me when you want feedback.
I think that means he
Because,
has feedback.
I have an opinion, but okay, you just go ahead.
Remember we're rookies here, like.
I do remember that. I do indeed. Ooh. Chris is like the chillest patient ever.
The perfect patient.
Great. Now, everybody that is a mock patient for him moving forward, scream, cry, difficult. Okay?
How do we know that the perpendicular
You have to eyeball it.
eyeball?
Yeah.
Oh.
I mean, the only other way to be sure that you're perfectly perpendicular would be to take the x-ray tube and actually make it touch the x-ray board and then move it back. We're not going to do that. We're just going to look at it and kind of get an idea.
How do I lock?
You don't. That's one of the enjoyable things about a portable too.
Just suggestion. That was a suggestion.
It's just going.
Big Bertha needs to move forward.
How very dare you call her Big Bertha?
It looks like Big Bertha. Like, I don't know, don't they call things Big Bertha? Like the machines?
Yeah, we
Or they talk about cars like that, like Big Bertha.
She's GE, so maybe Gertrude.
Something I could pronounce, like
Watch your toes, April.
you can remove one, it's not gonna hurt anything.
This is one, I'm serious, this is a real world thing. I had this issue happen one time when I was trying to get a trauma.
More, then can't you just do that? Or closer? There you go.
There you go.
No.
Nope.
Nope.
Real world problem.
25 years old machine.
Why is there no way to block it though?
Because they just don't make them that way.
But just like you can't lock
There was a
yourself.
time when it didn't rotate
It's
like
portable. It's mobile.
I thought this one was supposed to be the fun one.
It is the fun one. Aren't you having fun?
Not really.
So then you deal with this when you actually do mobile x-ray, like out of the hospital, going to places, and you deal with this all the time. More
This kind of
so?
thing? I've never done any portable outside travel work. I've never done that. So I don't know what it's like.
Because I figure if you move this a lot, it will become balanced.
Oh, thank
Best friend.
Did the light go out?
Yeah.
Oh, it's because it got too hot. I'm telling you, this portable is it's on its last leg.
Now it needs to cool down. It's not like the old Nintendos where you blow on it and it cools off.
Which Nintendo?
Like the first, before you were born.
Is it kind of? Yes,
You know the old one where you blow in the thing? You ever seen that?
Okay.
Where the game
Oh,
goes?
wow. Okay. Great.
You did it.
Now
Now
we-
it's out.
Take a deep breath in for me. Deep breath out. Deep breath in. Hold. Alright, you can breathe.
Chris is going catatonic, guys. All right. Who's next?
So literally when it says figured out, you gotta figure it out.
Yeah.
Okay.
Yeah.
You said you had it. Oh, I switched the.
You were good.
Okay.
I think you did it. You fixed it. As I said at the beginning, and no joking intended, what we learn here in the lab is as close to optimal as it will ever be. When you get out into the real world, you will have a cascade of things. I am not exaggerating to say every patient encounter will be specific and unique and different for you moving forward. Optimally, the best scenario is I go to the waiting room, I get my patient, they walk back, I say stand here, they stand here, great, and they're out. It's easy. Outpatient is probably as easy as it gets. When you get to a hospital, that's where you start to have to be much more creative. Yeah.
You're also dealing with like psych patients. You're dealing with a lot of different patients.
Yeah.
I walked into the ER one time, patient's not in their room, not on the bed. I look in the corner and they're huddled in like a praying position on the floor. So gotta call the nurse in. She grabs a couple guys, picks up the patient, puts them on the bed, and then they're still contracted, so you still have to figure out a way without ripping their arms off to get the image.
How did you do it that day?
So you get them, turn them on their back using everything you can, every pillow from every room you can find, so that they're on their back, and then don't move their arms if they're contracted, but you're gonna stuff some things between their arms so that it's coming out. Yeah. And then typically if their head is down, you want to bring the bed down so that their head naturally goes back. And that way you shoot it without anything. Yeah. What position is this called when the head is down and the legs are up?
Yes.
Yeah. This is also the easiest way if you're alone to move your patient up. You're not always going to have help. So sometimes the patient's head will start right here and you want to bring them up there. So you're going to bring the head down, grab your sheets, and go up.
Demonstrate that real quick?
Oh, yeah.
Let me go to the other side. We'll do it together. So if he was like really low. Great. On your call.
Yep. 1, 2, and 3. There we go. See how easy that was? And now he's up.
So she's really are your best friend.
Yeah. All the time.
And the bed. Take advantage of the bed.
The beds on portables, if they're in the ICU, hospital beds are great because you can max inflate them, and that makes it easier to push your descent under their body if they're really large.
And sometimes there's a pocket in the bed. Even better.
True. On newer beds especially.
Yes.
A pocket?
There's a pocket inside of the bed, so you don't even have to touch the sheet or anything. You just unzip the bed, push the, yeah.
Oh, between like the mattress and the plastic?
Yeah.
Growing up in the easiest time.
Yeah, we're walking into the easiest situations.
Who are you? You position?
Yes.
Go ahead.
Hi, my name is Chris. I'm the RAD tech.
And you may have to do
Josh, February 27th.
orthotic decubitus tomorrow.
And you're gonna take
Ooh, we went overtime.
If that works, because we may have time. We're at 11, but we've got like an hour and 10 minutes. I really feel like today I didn't want to on mark.
Okay.
I think abdomen on Wednesday is going to be really good.
Yeah. Yeah.
Oh, forgot to show you how to do that. Up there, underneath, there's a little thingy. Should be
Right there. No, back.
No, that one.
hold on.
Right there.
I got you. So push that up.
The only thing I just know how to do is the
Also, know how to use stretchers before you leave this lab, especially if you're going to a hospital, okay? Stretchers typically have the same kind of mechanisms, and they have 3 settings for this little pedal here for the wheels. One is brake, obviously it will stop everything. When it's in the middle, that is all wheels being loose, and when it's all the way to the green, it's on steer, okay?
So the all wheels, like all wheel drive.
All wheels are open, so you can move. It's really free roaming. Really great if it's in an X-ray room. Not great if you're bringing them down from the floor.
And leave the patient the same way that you saw them. If they are all the way on the ground, the lowest level, they're on the lowest level for a reason, because they will flop off or something else.
Like that.
Exactly. So the way that you got them is the way that you return them.
Yes.
Typically, all the way low. You're never going to bring them all the way up.
Same if you go to a patient's room. If they don't come to the department.
Yes.
Leave the room better than you found it.
Yes.
Straighten up, yeah. Make them a nice meal. I'm kidding. No. Make sure if they have a sponge under their side, it's probably there because they are an inpatient and we don't want them to get a decubitus ulcer. So the patient has been turned a little, maybe for decubitus ulcer, maybe to facilitate drainage or something. Who knows? But just always put them back the way that they were. Okay. And better. And don't leave any of the rails down on the bed. If you leave the rails down, the patient falls out of their bed because of that. You are now in some deep doo-doo.
So a nurse won't be in attendance?
They may not be. If you need help, you can go try to get a nurse to help you. But, and this is not, it sounds like we're shading nurses, but we're really not. Nurses, this is a problem in healthcare, probably they have multiple patients that they are responsible for. And they're just not always available. Just the way it is. There may be a nurse aide. If you're lucky, you have a tech that goes with you, or a student who can help you. But most of the time, it's just me in a room sweating my butt off trying to get a cassette under somebody until hopefully somebody passes by and says, "Oh, do you need help?"
And you're in full PPE, so you're dying in the room.
Dying. It's sticking to my arms.
Yeah, it's the worst.
It happens, though, no?
Oh, yeah.
Trying to make it hard on you.
The only thing is, I feel like he's probably a little too angled. Just do that. Means you now have to adjust your stuff. I think that's pretty good. It's good. And what marker would you place on this and where?
I don't know.
That's it. Left on this side? So this is left? Yeah. Left or right. We could do either because it's AP. Okay.
Whenever you breathe in, breathe out. Now you breathe in again, hold it.
Great. Who next?
So then when you're enclosing your conversation with the live patient or the conscious patient,
Yeah.
How do you close out? Because we did all the beginning part, but how do you close out? Like, okay, I'm done with you, bye. Like,
So I've shot my x-ray. It's done. I put the exposure back. Okay, Mr. So-and-so, I'm all done now. I'm going to get that cassette from behind your back now. Okay, 1, 2, 3. Great. All right. Do you need anything else before I leave? No? All right. Well, I hope you feel better soon. We'll see you again. Hopefully never. Okay. Really nice.
And you don't want to be the tech that forgets the board behind the patient's back. Happens way too often. You get back to the department and then you're like, where's the board? And then it's still behind the patient.
And you also, very important, and you will refine this again as you go into a hospital. You don't want to not know. Is this 123? Is this 224? Which patient is which? I don't know. So always take your requisition for the exam. Most of the time there's a little slip that you can take from the exam requisition to slip or stick onto your cassettes. At Barlow, we are very fancy and high tech. We use tape and write the room number on it and stick it on the cassette.
hey, that's
Whatever
safer,
works.
The tape when
Yeah.
you're going nowhere.
Yeah, exactly. So make sure you know which cassette goes to which patient and which exam. If you have to do, so sometimes at Barlow I have to do a chest and an abdomen. Make sure you know which is which because they're not going to be under the same accession number. Okay.
And
Question.
for portables, right? Like that's like really important for portables.
I would say it's important always. If you have a patient who's getting like, let's say a T and L spine series, you don't want to mix those cassettes up. It's not impossible to fix it, but it's just a pain in the butt. Okay.
And then to identify the patient if they're unconscious,
You're going to look at their armband.
armband.
Yes. We don't rely on anybody's word because
Never.
you walk into a room and say, is this Mr. Jones? Yeah. They're not even paying attention to you if it's like a family member in the room. I literally, when I was a student, made that mistake where I took the word of somebody that was in the room. I was like, is this Mr. So-and-so? Yeah. And I setting up and I look at the armband halfway through it and it's not even the patient that it's supposed to be. Thank God I caught it before I exposed, but don't trust anybody.
Mm-hmm.
Don't trust anybody.
Psych patients?
What specifically about psych patients?
Like, do we sedate them? Like
We don't do any sedation.
Okay.
So if it's someone who's very combative, you could maybe speak to the nurse. If you try to do the exam and they're very unruly, you could speak to the nurse to see if they have an order for some kind of a sedation that they can apply right then, or you can say, I can't do it right now because the patient is very combative, and they will see about procuring sedation for you to come back. Yes?
What happens if like they have like the arm restraints? Like, is it
Never remove them.
Don't remove them and
Never.
just work
like,
around
you
it.
just take the X-ray if they have the restraints correct. Like you don't.
Yeah, you don't do anything different. You just do the X-ray still. At Barlow, we have people. I talk about Barlow all the time because that's my X-ray job. But a lot of those patients will be restrained, and hospital inpatients, especially geriatric patients, they're not necessarily psych patients, but because they're older, they could have dementia, and they hate an NG tube.
Mm-hmm.
They hate it. They will fix that index finger in there and pull it out, and you'll have to come back and do another KUB for placement. Don't remove the arm restraints. Work around them.
I've seen that with the mittens too.
Mm-hmm.
The mittens are terrible. They're crap because the patient will turn them around and then still get their finger under there to pull it out. So yeah, it's great. Anybody else? Jump in. We're starting kind of slow today. I didn't go into everything we have to do for the chest. We're going to do lordotic and decubitus tomorrow. Okay, we will save Wednesday for the abdomen. Okay, it's really great that you guys came in so prepared, and I'm not exaggerating. I'm really thankful that you guys did that because it means that we can really maximize on this time. Anybody else want to practice portable? Now's the time. This could be one that you pull for your midterm positioning.
It's heavier than you think.
That's right.
IR.
And you can put the side rail down if it makes it easier to get in the stretcher. Or you can do it that way. And remember, on a portable, you can still shield.
Never too late to teach that.
It's not an automatic fail, but be sure you're
17
shielding.
patients later. But that one, you just lay it on there, correct?
I'm like, I think this is good. Right?
What are we doing?
To put it down.
Ooh, watch yourself. Watch out.
I'm like,
Right here. Make sure everything is clear. Okay. On either side, you can grab this. Okay. And if you're trying to put the side rail down.
Hi, my name is Dimitar. I'm going to be your X-ray tech today. What's your name?
Oh, it's like,
What's your date of birth?
I think the chest XP is
We'll take a
yeah, that's why like I know like
slide this behind you.
Like
It can, if your place is healthy. So we use these in the floor. Sometimes the hospital doesn't have it. We can use a pillowcase, which in my opinion doesn't make it any easier. I have done both. I had my job at the ER, or my first job in Carolina.
I just wanted to ask because that's how I
You
see it
just
at
clean
work.
them.
The last year that I was there, they finally got plastic bags. It was only after somebody had taken a cassette into a trauma and filled the IV with
The price, I guess. Was
Yeah.
It has to be.
then again, this is 25.
Yeah.
Oh my God, same age as me. It's crazy.
Oh, I didn't know we were the same age.
Same age. It's crazy, right?
So far from it.
I think maybe we're a little. Collimation's a little too wide. Center maybe is a little too low.
Or is it going to be?
We're clipping kind of the top here, so we can bring it all up. There you go, and bring that collimation down. If that's not happening, then we can. Sorry, I blinded you. Character building, yeah. Character building blindness.
But it's not gonna show 10 ribs.
If he can take a deep breath, yes.
Okay. Can you breathe?
The more upright someone is, the easier it is for them to take a deep breath. Okay. Still not so.
So like what you asked earlier, you said you want to be able to see the first.
Yeah, and then the bottom, I will.
Can I have you take a deep breath?
Push your head back a little bit.
Breathe out.
Oh, I
Take a
see.
second breath, and you're gonna hold that.
See, you can see that.
Yeah, perfect.
When you have just deep breaths like this.
I know, and I did it earlier. I can see it.
This is for me to serve.
Professor. I have a question that I was trying to get about.
Sure.
When we're aiming the collimation, like I know it says 2 different delivery notch, but is that like talking about the cross under the delivery notch or like the light? Does that make sense? That's what's confused about.
The top of the collimation light is what you're saying?
Yeah. It says 2 different delivery notch. So like below here, like the light or the cross?
No, the cross should be.
So the cross should be below here.
Yeah,
Okay, not the light.
Mid-cern.
Okay, so.
The light, the cross, the light with the cross.
Oh,
Because where that cross is your central. Right.
Central.
The entire light is what you're gonna see on your screen. So if you're gonna include this much light above your shoulders, this much is gonna be shown on your image of just black. So that's why it's 2 inches above.
That's the moment right there, bro.
I wish this actually shot so like they could see.
Sorry. I know. You said learn it.
Or you need a projector, so you could say pretend and put up a screen.
I did some volunteering.
Put together a proposal for an active room. Maybe one day in the future we'll have.
But the other ones were way more new.
Make your life easier, Ennio. Okay.
I mean, it's
When you're doing this,
but the other ones was like.
grab the sheet, keep it taut. Then kind of get it to where you want it to be center-wise. And go for it. Okay. One quick fluid movement.
Well, that's what I was like, it's different doing it than you see it done. Like you feel the
You know the bones having.
yeah, right here. So probably pushing it towards the, you know, the cushion part more, so it can slide on the side.
Anything else you think I need to do?
Mm-mm.
Good for a first day.
Yeah.
Oh, there's a projector.
Yeah, you have a projector.
I do.
Where's the image that we're showing?
AKA.
You can put a slide on your phone. Is it probably Bluetooth too?
You know what's
Shut up, April.
funny about you? You remind, and this is not about you asking questions or anything, you were just saying. You remind me of my instructor in my bachelor's program. Like, so much.
Really?
It's crazy. It's
Well, why don't you do that? Go. Don't change the subject. I'm saying that, like, when we're practicing, you could put a fake image on what it would look like. I'm just saying, like, you don't have to do it today. I'm just hypothetically.
Oh, no.
Then we
No.
can see what it should look like. Okay, so this is what it would look like,
Pull it down.
right?
No, we're gonna do it now, April. We're gonna do it now.
Thank you.
And I want you to stand there and look at it.
I
for
want
30
the full
minutes.
$60,000 I'm paying to effect, okay? That is part of it. We have a fake picture. I need to see a fake picture like. But it helps. I'm just saying.
No, I love April. You're so good.
Thank you. Sorry. I'm sorry I make you work harder.
I'm not.
And then he's probably we leave and he's like, dang, thank God she's gone.
So, not at all. I have definitely never said that about you, but definitely said it about other students.
Thank goodness.
So this is a portable chest. Knowing what you know about the evaluation criteria now, what would you critique about this x-ray?
He's crooked.
He's
not
crooked.
upright.
Which way is he rotated toward?
The left.
He's rotated
to
toward
the
the
right.
right. Why do we know that? Because the SC joint on the left closes off and the right one opens up. Okay?
Oh, I didn't know that because of that. But
This SC joint is moving closer to the spine. This one's wider now.
oh,
Okay? So he's rotated toward the left. They did not put a marker on it. Is the inspiration sufficient on this x-ray?
No.
How do we know?
The amount of black. Amount of this.
The diaphragm?
I'm going to need you to use some actual x-ray words instead of the amount of
you know
this.
what? It's okay. I understand. All right. I
So-
get it. It's because of that.
Is it the diaphragm?
So there's a diaphragm, right? 1, 2, 3, 4, 5, 6. Probably nothing we could do about it. One thing we'll know that you will know moving forward is that 10 posterior ribs is the optimum situation. On a good patient, we will get 10 ribs. They will be able to take a good breath, especially if there's nothing wrong. If they are in the ER or an inpatient and they are in the hospital for a reason, they might not be able to take a deep breath because maybe they have a lung infection, like they do here, upper lobe consolidation. Okay.
But technically, you could see the ribs, even though, but you want to see 10 ribs in the airways. Is what you're saying.
I want to see 10 ribs in an open chest.
Okay.
Okay. If they can't take a deep breath, and this was shot erect too, so he was upright to help him
Breathe.
get a deeper breath, to help those diaphragms go down, and he couldn't. So either they took it too soon, or he couldn't get a deeper breath. Okay.
There's something in it. I feel like a line.
This is an NG tube.
Mm-hmm.
NG tube. I don't see any other lines. Rotate a little to the right. Upper lobe consolidation, right there. That's what a radiologist would say about this.
So we can still use this X-ray for a diagnosis, even though it's
Sure.
not as good.
What you'll see on the report is the radiologist will probably say, single view chest X-ray presented. No, patient is rotated slightly to the right. There's evidence of right upper lobe consolidation. Rest of the lung feels still clear with insufficient inspiration. Cool. Questions?
I have a question.
Yeah.
Sometimes it'll look like that if they are positioned correctly, but that would be more so because if it's a pleural effusion or something like that, or no?
I'm sorry, ask one more time.
So if they're positioned straight,
Yeah.
and you take the image and it looks exactly like that, is that because of?
You mean in terms of the inspiration?
Right.
It could be due to patient discomfort. It could be due to the lung disease that they have. I'm telling you right now, if you've got that much of a consolidation in one of your lobes, it's hard for you to take a deep breath. It probably hurts. Questions?
And the crookedness can just become because they're older and they're
It could
formed
be.
that way now.
It could also be lazy X-ray tech. They could have just gone, shifted their butt a little bit, and rotated them. We don't know what the situation was.
But there could be multiple ones.
Absolutely. Patient discomfort, patient situation,
Scoliosis.
scoliosis, contraction.
But it doesn't look like that. It looks like the tech could have fixed the patient.
With
Is
a
it
pillow.
always a radiologist's job to add like feedback on the photo? Or on the image?
They read what they see. If they're a jerk radiologist like Dr. Warren in North Carolina, ask me how I remember that name so well.
Because he was a jerk.
He's a jerk. He starts his reports by going, single view of the chest was presented. Unfortunately, the technologist did not rotate the patient slightly to the left, so the X-ray is slightly rotated to the right. And he always made sure to make that little jab at us. In this case, he wasn't wrong, though. They could have rotated the patient a little bit to the left. Fix that. Good job, guys. Let's see if we can look at
See,
another
we
one.
learned something from the picture.
April, we're gonna fight in the parking lot.
It wouldn't be the first time.
All right, what's going on with this one? Oh man, so many things.
Yeah.
What would we critique about this?
The faces in the picture.
Yeah.
Oh yeah, he's like.
Oh, that's his nose.
That's probably their nose. They're probably like this.
There's a reason the tech didn't put their initials on this.
They were not proud of this. This was also a portable. What are these?
Those leads, those sticky things.
EKG leads. Yes. They have done their best to wad them up over here. What is this?
Read a tube.
ET tube. That's the vent tubing. Yeah. We don't have a feeding tube on this patient. What is this right here? Not this. This. Somebody said it. Gastric bubble. Yes. Normal to see the gastric bubble. Should I see air under this diaphragm? No. If I do, that is an abnormality. Yes, we need to bring attention to it right away because it means the patient has a perforation. That is an emergency. Okay. Looks like they've got some kind of a lung issue happening here on both sides. Okay. Good job. A little bit of a pleural effusion here because we don't see this costophrenic angle, right?
So when you notice something that's urgent, you're not gonna just send it to the radiologist like on slow.
We're gonna send it to the radiologist.
Oh, you still are?
We're
You
not
don't
really.
even put like this is.
No, there was a tech that I used to work with who felt like he had to find every pneumothorax and point it out. The radiologists are well trained in finding pneumothoraces, and if a study was ordered stat, everybody in the chain knows that we need to get on this right now. And usually, a patient situation that warrants the ordering of a stat exam is going to be watched like a hawk from the moment it's ordered, because there's a very specific reason why the attending physician was like, I need this x-ray now. Okay.
So
This
it's,
patient's
it's automatic. It's,
yeah.
You don't have to do any extra.
They may have started coding, they may have had a desaturation. Nobody knows. Let's see. Oh, what do we think of this one?
They're in love.
I'm
just, they have a heart necklace.
I'm letting you know that there's never going to be a day that I'm like, I need you to go away. I love the commentary.
I'm sorry.
Was it too late out because of the arms and stuff?
Sorry?
Like the collimation because of the, he got the arms as well.
Good point. So, quick question before we continue any further with the discussion about this x-ray. What type of patient is this? Not body habitus. Age. Age. What is the age of the patient?
Oh, you know, older.
Is it an adult or a child?
Oh, it's a child.
How do you know? Besides the heart necklace.
No,
The heart necklace. But the growth plate.
Yes.
But it's
They
called
have an
something else.
epiphyseal
What is it?
plate.
Yeah.
They have an epiphyseal plate visible on the proximal humeri. Okay? And the heart really gave it away. So it was probably carelessness on the part of the tech, because this was probably an emergency situation, actually. These lungs actually look like she's developing a little bit of a pneumonia. Maybe. I don't know. It's not a great image.
How do you know it's a she?
Could be he. Could be he. Who knows? As far as the rest of the evaluation criteria, how do we feel about the rotation of this?
What do you mean rotation?
Is it straight on or is it a little rotated?
It's a little rotated.
To which way?
To the right.
It's a little rotated to the right.
Well, I would say the bottom is to the left.
So this SC joint is now over the spine a little. This one's a little more open here. Okay, so they are like this a little bit. Okay. Questions?
Wait.
can I try
Do that again?
I was like,
So put your fingers on your SC joints here. Okay. If I rotate this way, this side's closing up, this side is opening up. Actually, if you want to do this, put these here. When I rotate this way, this side, well, it's not a great way to do it either. I think it's a good way to teach this.
I can feel it. I can feel something.
It opens up when you're rotated toward that side. Okay? So if you're rotated toward the right, this side opens up, the right side opens up. Okay?
So you're busted. You know you're
Busted. Busted. Also, shame on them for leaving that necklace on, because that's a huge artifact. We'll give them a pass, though.
But you said the collimation needed to go in more, right?
Mhm.
Absolutely. We don't need all those arms.
Okay.
Yeah. Ooh, that's a good one. What's our evaluation criteria on this one? Is all of the anatomy on this x-ray?
No.
Where is it clipped?
On the right side.
On the what side?
Right.
Right side, yes.
Because the bottom thing is not showing. Whatever that.
So we have the costophrenic angles. I'm not worried about that, it's close. But we don't have this border of the chest, okay? Long lungs though. How many ribs do we see?
10. At least 8 to 10.
Now, how many do you count on this one? 1,
Is this the 10th one?
2, 3, 4, 5, 6, 7, 8, 9, 10. Almost all of them.
Is that
That's
this
12.
one? Right here?
Yeah.
How do you count the first one again? Can you show me that? Because I get so confused.
1,
Oh.
2, 3. So 1 is always the one that you see
So it's technically not a one, it's a, it's a, it doesn't go, actually, never mind. It stays the same, you're absolutely right, it's one, it says one right there. But I'm just saying, like.
One, 2 and 3 are kind of clumped up.
Okay.
Start at the uppermost, okay? 1 is going to be the easiest to find, okay? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
So are the first three usually just like kind of
Yep.
more compressed?
Okay. Anything else about this? What are?
I could never, I'm like, where did you see one? I don't.
We're going to look at another one. Because I do think this is important for today too.
I see the one. I can count it now.
Whoa. Okay, evaluation criteria on this one. What do we think?
Collimation is
A little bit
off.
off-center, right?
Maybe just
The
a
marker?
hair. Just a hair we could collimate. Maybe a little bit more from top to bottom.
Maybe
Is it rotated?
very well. I think I don't think it's rotated. I think the central ray is machine.
I would say maybe if it is just a hair to the right, but not enough for it to be even noteworthy. How many ribs do we see?
6 to 8.
Who keeps saying 6 to 8? I want
No, I can't
the
really see
number.
from here.
10. The number.
One
1,
goes down
Looks
like
like it's 8.
2, 3, 4, 5, 6, 7,
9.
8, 9.
I was right.
I can actually count the ribs now. I'm like, oh.
So slightly hypoinflated. Marked correctly. This was a PHS for sure, because the marker is backwards. We all understand that distinction, yes?
Wait, say that one more time.
The marker's backwards,
Yes.
so that's how we know it was PA.
Oh, okay.
Okay? When we hang it correctly, the marker should always be reversed on a PA.
Gotcha.
Okay?
And you somewhat got a Y view.
Yeah, the collimation.
A little bit of a Y view.
Yeah, they could have collimated a little bit more. Yeah, it's like a weird oblique. Because that one is a little more open than that one. Just ever so slightly. This joint space here, that SC joint, is a little bit more narrow than this one.
I'm good right
What about this one? What's the age of the patient?
Definitely a kid.
Infant or toddler.
Definitely a kid. Is it rotated?
No.
No. How many ribs?
8 to 10.
I know you can't count 10 back like that.
I just tell.
Oh.
I could be wrong though. I've seen 10.
All right. 1, 2, 3, 4, 5, 6, 7, 8, 9.
8 to 10. That's what I said.
Kind of 10. We'll give them 10 on this one.
You just pick 9, you'll probably be right all the time.
All right. I think we're going to be just about done looking at these.
Sorry, on the last picture you put up,
Yeah.
there was a shield around,
No, I don't think so. Let's see. Where was that one? No, that's just neck fat.
That's a chunky baby.
It is what it is. All right. So they've done a no-no on this one. You will see this in your clinical rotations for sure, that people use digital markers all the time. I am telling you right now, do not use digital markers. I am sure some of you will be coaxed into using digital markers. Nor do you use digital markers?
No, never.
Excellent. Why don't we use digital markers? Anybody?
It could lead to errors.
Errors. Absolutely. My favorite story is the guy who had a leg amputated because it was not marked correctly because the tech used a digital marker. They got confused about which way it was flipped. They put a digital marker up there. It was the wrong one. Patient had a leg amputated.
That shouldn't be a favorite story. That should be an unfavorite favorite story.
It is my favorite horrible,
Yeah.
It's like a
awful,
horror
keeps
story.
me up at night.
Yeah.
Yes.
What happens to the tech after that?
Bye.
We'll take a guess.
You got fired.
They were promoted.
To work from home.
What do we think of this one?
Collimation.
Evaluation criteria.
I think it's flipped. The thing is flipped. No.
We don't know that because they use a digital marker.
It's a little silver.
I actually think the rotation it's actually really symmetrical for the most part. So great.
I think it looks good.
I think it looks good. The only thing I would have done differently is not use a digital marker. We can see that there's a good space between the costophrenic angles and the apices is about the same. Lung fields look good. How many ribs do we see?
9.
6 to 8.
He never says 6. He always says 8 to 10.
If I see a diaphragm is below, I say
10. 10 posterior ribs we can see. Great. Scapulae are out of the lung fields entirely.
But could you collimate in more though, or no?
Yeah,
Are you
a
sure?
little
You
bit.
could. I don't know that I personally would that much more. Would you?
Just like a
Just
tiny
like
bit.
the tiniest bit, because this actually will kind of affect your histogram applying. All of that black gets averaged into everything. So you could kind of collimate in slightly because they're a thinner patient.
So this is what we were practicing standing up.
Yeah.
So this is what it would look like.
Yes. Yes, April.
Just making sure. You gotta put 2 and 2 together.
All right, let's look at a lateral. If I can find a lateral. And then, woo,
it's horrible.
it's probably a little old lady. So she's a little kyphotic. So what do we think of this one? Evaluation criteria. I don't love the way that it's flipped. I probably have left it alone.
It doesn't look like it's the
I don't even know.
Is it cut off in the front? So it's this way and
Is
then
that considered maybe lordosis or scoliosis? I don't know.
This is kyphosis.
Kyphosis, there you go.
So she's got very what are called osteopenic vertebral bodies. You see how radiolucent they are? It means her bone density is very, very small, very low. This is her arm. Probably couldn't be raised any higher. Yeah. So she's got to be very careful because if she fell, she would definitely like shatter. They could have maybe gotten her arms a little bit higher, but probably couldn't have because of the patient's situation. Overall, though, there's no rotation that I can see on this lateral. I see the posterior ribs are in alignment, they're overlapped. Diaphragms look like they're lined up too. Questions?
What was the diagnosis on this?
Little old lady. I'm not sure what the diagnosis would be, besides the fact that she looks like somebody who, though, has had an issue taking a deep breath for a while because her diaphragm is very flat. So it seems to me like she's had to do.
Yeah.
She may have a little bit of emphysema. Maybe she was a smoker. Apart from that, though, she just got very bad osteopenia. She's probably got osteoporosis.
So be gentle when you're doing her
Be
exam.
very gentle with her. Don't body slam her like all the other patients.
Like, get it done. Move.
Get it done, lady.
Put your arms up now.
April, patient care rep of the year.
I was kidding.
Any questions on any of that?
I mean, we're still able to post-process. I mean, anything. We can still post-process.
Sorry?
We can still post-process any of the images. That was just a question.
For what?
Just in general.
I mean, you can change the contrast and brightness, yeah. But I also wouldn't do that too much because, again, if we do too much of that, it limits what the radiologist can do when they receive the image. We should get it right pretty much the first time. Our technique is right, the system's set the way it should be, our image should be exactly what we want it to be. Questions?
I have one more question.
Yeah.
Sir. I mean, obviously, besides being our own critic, are we going to be obviously reading the diagnostic images? Are we doing right now? Reading the diagnostic images after we take them, or is that obviously radiologist?
I mean, you're going to have your image pop up on your screen, and you're going to take a look at it and determine whether or not you need to reshoot it. Once you're a tech.
Yeah.
Before
I was saying
you're a
like
tech.
diagnosis they're talking about.
Oh, diagnosis?
Yeah.
No, you won't have to know the diagnosis, but you will probably start to have some familiarity with what you see.
You'll pick up on it, but you don't share any information. even to your best nurse friend who is asking you if the G tube is in, you say, I don't know, and you walk back to the department.
Well, luckily, I'm not going to be friends with the nurses.
It's so easy though to make that mistake because if you see, like at Barlow, I have to do. They call me at 1 o'clock in the morning to go do a KUB to check NG tube placement, and the number of times that I have someone, an attending, or the nurse go, "Was it in place? Can we use the G tube? NG tube?" I don't know, because if I say yes and that thing is coiled in a lung, and they start feeds, they're gonna kill them. Right?
Well, actually, you're gonna kill them because you said something.
Sometimes,
It's on you.
sometimes you so badly do want to say something so you don't have to walk back up. You know that it's not in, so they're gonna change, like they're gonna fix it right when you get back to the department. But you gotta do what you gotta do. You can't say anything.
Fix it and call you back down to retake the photo again.
Yeah, and you know it. Like you're looking at the image and you're like, okay, I'm coming back in 2 minutes.
Yep. Let me tell you, the worst thing is when I do get that call at 1 o'clock in the morning, and I have had patients where I have done the chest X-ray or the KUB to see where the NG tube is. And I process my X-ray. My X-ray is usually half chest, half abdomen for an NG tube. And there was one time I remember I shot the X-ray and I saw this.
Oh yeah.
1 o'clock in the morning. So guess what I knew I was going to be doing again?
Waiting there.
Another X-ray, because that NG tube was coiled in the esophagus. It needs to be in the stomach, because if they start feeds with that tube in the esophagus, all those feeds are going to fill the esophagus and spill over into the airway. No
Wait,
bueno.
so whose job is it to fix that after?
The nurse.
The
after they got
nurse.
the report. So they can't use that NG tube until they get the radiologist report verifying that it's in a safe place. If it's not, then they have to do a revision, do another X-ray, get another report. It's an annoying process, but.
Must be bad too.
Oh, a lot. That's very
So
often.
the radiologist that has to be like, oh, you have to fix that, and then
The radiologist says NG tube midline, but it appears to be coiled in the esophagus. Yep. Yep.
Is it like the same thing when they put in like lines, like thick lines and stuff?
We have to do a placement confirmation.
Yes.
Okay.
Because if the tip of the PICC line is too far in, it can cause irritation to the right atrium, which could cause some kind of an atrial fibrillation. Because it irritates the inside of the heart. Questions?
Luckily, you're just taking a picture.
No, yeah.
Unless you want to be an RA one day.
No.
Yeah, question?
Do we also put in, say like since position, do we also have to, do we put in the very minimum tip? Like do we put in the minimum?
We put in the enema tip. Yes.
I remember your story. I cannot get that out of my mind. That
Wait, is it
story.
my story about the little old man?
Yes.
Yeah.
It says that. Yes.
Yeah. That's my favorite story to tell.
Now that is a horse. That shouldn't be a favorite story.
It was a horror story. And I loved the tech that I worked with, Martha. She was so great. God, I love her. I'll never forget. That patient lost the enema while he was standing there. It went all over the floor, and Martha went, well, I'll let you clean that up. Questions? Somebody else? Yeah.
No, are we able to press it on each other?
No.
No, I'm just kidding.
Ha ha ha.
Yes, but we'll let you be first.
That was a good one.
Question. Any other questions? Does anybody want to practice PA and lateral chest?
Oh, I was scared what you were gonna say. Practice. Hold on.
PA and lateral chest or wheelchair chest, since we're here. I want you guys to feel very comfortable with these today because we will not revisit them this week unless we have time.
What wheelchair besides the
Sorry,
stretcher?
stretcher.
Oh, see, you gotta be accurate
I know,
here.
I know. I'm
Come
sorry.
on,
I'm
'cause
sorry.
wheelchair you said is
I'm sorry.
different.
You're right.
Thank you.
Different but the
Making me
same.
confused.
Question.
Can I have a patient? I would like to try. A patient? Anyone want to know?
Say it with gusto.
Okay, I'm like, sorry.
Threaten them.
I want all your guys' information.
Oh, thank you. You're welcome. You should just add it to yours in the back. She loves it. She's like,
I'm telling you guys though, knowing what you know in terms of the SID, the centering, the evaluation criteria, you have set yourself 75% up for success. The positioning is really the easiest part after that.
Yeah. I think they all lost.
At least in my opinion.
Yes.
Absolutely at a good start. If you know all that, you're doing really well.
I told you it's different when you get up yourself. You're like, what?